Hello, everyone. Once again, I welcome you to my psychology lecture series. Today, we are looking at personality disorders. Last time, we are looking at personality and personality assessment and what we learn in assessing personality. And so, today, we are looking at the personality disorders. The following are our lecture objectives for today. Number one, understand the meaning of personality disorders, discuss the general symptoms of personality disorders, classify personality disorders, and then give characteristics, cause, diagnosis, and treatment of each disorder. So each disorder that we are going to mention, we're going to talk about all of this information regarding that particular disorder. So we get started with important terms. Number one, personality. We saw these terms when we are discussing personality and personality assessment, but it's crucial to first repeat them so that we can get oriented well with today's topic. Personality refers to the characteristics or traits that are expressed on a continuum of social functioning. In other words, the way someone as an individual behave, or some characters that individuals portray. That refers to their personality. Then personality disorders reflect personality traits that are used inappropriately and become maladaptive. In other words, personality disorders is the abnormal personality. Some deviations may be quite mild and interfere very little with the individual's home or work life. Others may cause great disruption in both the family and the society. So, the deviation we are talking about is deviation from normal personalities, normal characteristics. Good. So, other terms that are important is psychosis. We are going to see that it is going to be used a lot in our personality disorders, each and every disorder that we are discussing. Psychosis is a mental state characterized by a disconnection from reality. That word is reality. Yes. So, often involving hallucinations, delusions, or distorted perceptions. Um, yeah. So once an individual has a disconnection from reality, that means that they are psychotic. Yeah. In other words, they start experiencing what other individuals are not actually experiencing. We are going to see that the psychotic characteristic is going to manifest a lot, almost in each and every disorder. Then schizophrenia is a chronic psychiatric disorder characterized by disturbances in thought, perception, and behavior. In other words, uh, it has now the manifestation of the psychotic manifestations. Psychosis is the disconnection from reality. Now, the manifestation of the disconnection from reality results into schizophrenia. You get it, eh? Yeah. So schizophrenia usually presents with hallucinations, delusions, disorganized thinking, and impaired social functioning. In other words, like I've said, it's the manifestation of psychosis. Then hallucinations, of course, when an individual senses stimuli that are not actually there. In other words, hallucinations can be audio when an individual is hearing sounds that actually other people are not hearing, or with sounds which are not actually in existence. Or tactile hallucinations, whereby an individual is feeling like he's being touched by something, but actually is not touched by that particular thing. Then visual, someone is seeing, in some cases report in our health facilities that whenever in the night, whenever they are alone, they can see men putting on white clothes. All their bodies are purely white. You understand? Eh? When you ask them, where is that person you're talking about? When you're not seeing that person, but this person with this patient is seeing those people. So those are visual hallucinations. Sometimes they can manifest as audiovisual hallucinations. In other words, when someone hears the sounds and sees things that are not actually present at the same time. General symptoms of personality disorders, we have difficulty getting along with other people. Someone will not socialize well. It may be irritable. It might be over demanding. Someone might be hostile. You cannot just deal with them. An individual is fearful, is manipulative. You want to utilize other people's resources like nothing and things that are in line with that. Patterns of behavior deviate markedly from society's expectations and remain consistent over time. Yeah, so for that case, such consistent deviation in normal personalities, like I talked about, is also a general symptom for all of these disorders. It manifests Then disorder affects the thought, affecting emotion, affects interpersonal relationships or impulse control. Such a disorder is a personality disorder. So long as someone is thinking is affected, emotions, relationship with other people. Remember, personality goes direct to the cognitive psychology. You understand? Eh? Yeah. So whenever we have a deviation in a thinking, an effect in thinking, an effect in emotions, you understand? An effect in socialization with others, such a disorder is related to personality. Also, another symptom is when the pattern is inflexible and occurs across a broad range of situations. That was also another symptom for a personality-related disorder. The pattern is also stable or of a long duration. In other words, it's tending to be chronic and it is beginning in childhood or adolescent. Such a disorder is also related to personality. Then now the crucial part of this lecture is to do with classification. You see, in personality disorders, we have 3 classes. You get it? Eh? They are classified depending on the DSM-4 classification, and we have 3 clusters. These clusters contain 10 conditions, and they are considered the personality disorders. They have some things in common, and such characters in common were based on to try to categorize them into clusters, as we are going to get oriented in our subsequent slides. Mental health professionals group those that share characteristics into one of these 3 clusters. Just like you're seeing them, we have the OD personalities that is under cluster A. We have the dramatic personalities under cluster B. We have the anxious personalities under cluster C. Schizotypal, schizoid, paranoid, these are all under cluster A. Then histrionic, narcissistic, antisocial or borderline disorders are all under dramatic disorders. Then anxious, someone is avoidant, dependent, or we have also the obsessive compulsive personality disorder. You see, this is obsessive compulsive personality disorder. Yeah, so I guess you get that correction. It is the obsessive compulsive personality disorder. OCPD and OCD, they're actually different. There is the OC of personality related, and then there's OC in other categories. Beginning with the schizotypal disorder, these personalities are characterized by OD forms, so it is under cluster A, of thought, perception, and beliefs. It affects a lot on how someone is thinking, on how someone is perceives the environment, and how someone on someone's beliefs. It does not occur exclusively during the course of schizophrenia. We have talked about this condition. Or during the course of a mood disorder with the psychotic features. When we talk of psychotic features, we said psychosis is a disconnection from reality, while schizophrenia is manifestation of psychosis. So psychotic features, in such a case, does not take. We do not have an exclusive occurrence in this condition. Another psychotic disorder or a pervasive disorder. Characteristics of the schizotypal personality disorder. Once an individual or patient presents with 5 or more of the following in your facility, then they will be diagnosed of the schizotypal personality disorder. To start with, OD beliefs or magical thinking that influences behavior and is inconsistent of subcultural norms. Then we have the unusual perceptual experiences, including body illusions. You get it? Yeah. And then OD thinking and speech. By OD, we mean actually something not not experienced by others, something unusual. If I can give an example, undressing is something okay. Undressing is very okay. But where are you undressing from is now what brings the questions. If you're undressing from your room, you're naked, that one is okay. Or from your bathroom, that one is okay. But it becomes odd when you undress from the public. So what I mean odd is something unusual for human in nature. So when you have odd thinking or odd speech, someone has a vague speech. It is metaphorical. They are trying to bring in more words that others find it hard to understand them, over elaborative, and then stereotyped speeches and thinking. These are all can be considered odd. Suspiciousness, someone's always living in suspiciousness, is suspicious of others as if they want to attack them, things of that nature. Behavior or appearance that is odd. We talked about this. Eccentric or peculiar. If I can give an example of appearance, odd appearance, sometimes we receive cases at our facilities. In one of my lectures, I gave you an example that for me at my facility, before I diagnose the patient's condition, I first look at their appearance. I first check on their fingernails. How are they appearing? I first check on their hair. Is it well? Is it tidy? You get it, eh? What they are putting on the clothing. You understand? Is it necessary in that category? Yeah, then the appearance will give me that will tell me that this person is not actually just mentally ill, but is having a personality disorder. So lack of close friends, someone does not have close friends, other than the first degree relatives. Someone will have the first degree relatives. That is mother, father, perhaps some brother and sister, but other close friends, someone has no close friend, then it will also contribute to the diagnosis. Then number 7 can be excessive social anxiety that does not diminish with familiarity. It's not that you're not used to the people you're around with, but you just fear them. You just fear being around those people. That's what we mean by social anxiety. Then the etiology of the schizotypal personality disorder, it is strongly related to genetics, in line with schizophrenia. Then it has signs of signs of CNS dysfunction. That's also part of the etiology. For example, impaired smooth pursuit eye movements and things in that line. Differential diagnosis, what would you depend on? Of course, I gave you the characteristics in the previous slide. You check 5 of them or more, then someone shall have confirmed the schizotypal. Or we can say, if it closely resembles the prodromal or residual phases of schizophrenia, where psychotic symptoms are present in an attenuated form. In other words, there are some psychotic symptoms. Yes, an individual is presenting with some detachment from reality, but not completely. They are the complete psychosis in that category. How do you treat schizotypal disorder? We can use antipsychotic medications, for example, aripiprazole, olanzapine, or risperidone. They are very, very good antipsychotic. We are trying to treat the symptoms. Most of these mental disorders, personality disorders, by the way, they are managed with antipsychotic medications. We are going to see them. Also, since it is a personality disorder, part of the treatment is the supportive therapy, which includes the social skills training and the supportive psychotherapy. You get it? So it's called generally it's called the supportive treatment. When we try, sometimes we can try to bring you some close friends to talk to, like that. That's supportive treatment. And then, in other words, the goal of the treatment is we were targeting the symptoms and as well treating the causative of the personality disorder, like that. Going to the schizoid personality disorder, still under cluster A, individuals with this personality are characteristically detached from social relationships and show a restricted range from expressed emotions. Their social skills, as would be expected, are weak. They don't socialize well, and they do not typically express a need for attention or approval. It does not occur exclusively during the course of schizophrenia or a mood disorder. It is a mood, okay, schizophrenia, a mood disorder with psychotic features. Yeah. So that is the schizoid. Someone has detachment not only from reality but from social relationships. Yeah. The difference with the schizotypal, someone will have some relationship with the close relatives. Yeah. But in the schizoid now, no close, no nothing. It has nothing to do with anyone. Someone has detached from social relationships. Characteristics which will also aid in diagnosis. You choose 4 or more of the following. The patient neither desires nor enjoys close relationships, including part of the family. They are almost always chooses solitary activities, just want to be alone, just like that. Has little, if any, interest in having sexual experiences with another person. Takes pleasure in a few, if any, activities. They don't have hobbies. They don't have hobbies that seated there enjoying something. No, such a person lacks close friends or confidence other than first degree relatives. But still, even these first degree relatives, he does not so much. He's not so much into them. Yeah. appears indifferent to the praise or criticism of others. He's all kind of he feels like he'll be criticized when he's around people. That's what we mean by that. Then it shows emotional coldness, detachment, or flattened activity. In other words, they are not so much open. They cannot be open to you or to other relatives. Then the etiology of the condition, it has a strong link to genetics. Also, excessively low ability to experience positive affects. That is also, now this one comes from experience as an etiology. The DD, differential diagnosis, we can say DX, yeah, DDX. Absence of desire for relationships, key difference from avoidant personality disorder. We shall see the avoidant when we reach the cluster C. It closely resembles the negative symptoms of schizophrenia. For example, the flat affect, decreased speech, poor motivation. Yeah, then we can diagnose schizoid. Treatment, it is the same for schizotypal. Like I told you, the goal of the treatment, we want to treat the signs and symptoms as we manage the condition. Treatment, we use the antipsychotics, and then management, we use supportive treatment. I talked about it. Then the paranoid disorder, characterized by an extreme level of distrust and suspiciousness of others. That is someone who is paranoia. Yeah, paranoid. He does not trust others and is always suspicious of them doing something. Yeah, they are generally difficult to get along with, and their combative and distrustful nature often elicites hostility in others. Others might think that he doesn't want people. He's even hostile. You understand? You cannot just socialize with him because they cannot trust anyone around them, not even family members. Such individuals are unlikely to form many close relationships and are typically perceived as cold and distant. They are quick to challenge the loyalty of friends and loved ones and tend to carry long grudges on others. Hope you get the difference from the other or the disorders. In other words, generally in cluster A, we have odd non-human characteristics. They are non-usual. You understand? Yeah, but the presentation now becomes different. For paranoid, it is suspiciousness in that category, and others we have seen them. Then characteristics of the paranoid, we shall select four of the following. Of course, there are four. An individual suspects without sufficient basis, but is suspicious of others, that they are exploiting them, harming or deceiving him or her. You will think that this person is just deceiving me. Things in that category. Is preoccupied with unjustified doubts about the loyalty or trustworthiness of friends. He cannot, even if someone tries to be loyal to them, they will never trust such a person. An individual is reluctant to confide in others, cannot have confidence in others because of the unwarranted fear that the information will be used maliciously against him or her. Such a patient is thinking that if I cannot trust this person, I cannot be confident in this person that I can give him or her my information. He might use it against me. Yeah. Then an individual reads hidden threatening meanings into benign remarks or events. What we mean here is that an individual looks at something, it's not threatening in any way, but for him, he's trying to read it, he's trying to perceive it as if it is threatening to harm them in one way or the other. Other characteristics, we have persistently bears grudges, is unforgiving for insults, injuries, or slights. You just step on him just by small mistake, someone reacts in a very in a very harshful way. You understand? Yeah, and he'll never forgo it. He will always keep it around that you did this on me, things of that nature. An individual attacks on his or her character or reputation that are not individual attacks, yeah, on his or her character or reputation that are not apparent to others and is quick to react angrily or to counterattack. In case just by someone's character, even if someone is just singing, can easily angrily attack such a person. Then he has recurrent suspicions without justification regarding fidelity of spouse or sexual partners. Someone does not have a justification, does not have any justifiable reason why they are suspicious. However, they are just suspicious, or is that perhaps their partner or spouses is actually cheating on him or her. Etiology has a strong link with genetics, but weak genetic link with schizophrenia, but a possible parental link in criticism and rejection. The DDX, the diagnosis, we can have paranoid ideation. It's not absurd, inconceivable, or bizarre, something unusual. Mistrust is generalized rather than isolated in one area. Is just not trusting anyone, just like that. A chronic cause rather than episodic. In other words, all these symptoms are presenting continuously in a chronic manner, not even just episodes. Yeah, like that. Okay. Then treatment, we shall also use the antipsychotic medication. The usual antipsychotic medications, olanzapine, aripiprazole, or risperidone. Because they target neurotransmitters such as dopamine and serotonin. Yeah, these are concerned with activity. May help psychotic delusions of persecution, but not generalized suspiciousness. These antipsychotic medications, like we said, they target symptoms, psychotic symptoms. Also, we can try to provide a non-confrontive stance in therapy. We try not to confront them in any way or the other. Then we have the antisocial disorder, now going to cluster B. It has a pervasive pattern of disregard for and violation of rights of others. They will never care for others. You understand? People with antisocial personality have been described as lacking empathy and may often be deceitful or break the law. When it comes to killing someone, they don't even hesitate. They don't have a minute. Even if they do something bad, they'll never feel that they have actually done bad to someone else. You get it? Yeah. Of course, they never regret their wrong actions. Despite being punished or jailed in certain cases, they continue to indulge in wrong and deviant activities. Yeah. Even if you punish them, they'll never feel like they did any mistake. Just continue doing the same thing. Characteristics of this disorder or behavior, any three from here. One, failure to conform to social norms with respect to lawful behaviors, as indicated by repeatedly performing acts that are not grounds, that are grounds for arrest. Someone knows that they will be arrested actually for doing this and this, but that person continues to do it. You understand? They will be blamed, they are condemned the acts, but someone continues to do that act. Also deceitful, as indicated by repeated lying, use of aliases, or conning others for personal profit or pleasure. They only look at their personal benefit. Failure to plan ahead, that is impulsivity. They will just do things the way they appear, no any link to planning. Then aggressiveness and irritability, as indicated by repeated physical fights and assaults with others. You understand? They can just provoke anyone because they want to create an attack. You understand? Then reckless disregard for safety of self or others. They don't even care about whether they are safe or something. If it comes to injecting themselves, they don't think of repercussions in the end. They'll just continue doing so. To get it? They're not just unempathetic to others, but even to themselves. You get it? Yeah. Then consistent responsibility. They continue dodging appointments. They just move anyhow, whether they are going to fall down or not. If it comes to climbing trees, whether it is accidental, you understand? If it is driving, whether they are driving in a bad way, they are never that responsible. Then we shall know they have antisocial personality disorder. Etiology, it has also strong genetic link and some childhood maltreatment. If the child was treated badly during childhood, then we have a high risk of antisocial disorder. Treatment, it is the most personality disorder, most difficult disorder to treat, but we can use mood stabilizers, for example, carbamazepine, valproate, or lithium. They may help to curb the impulsive disorder. Then prolonged incarceration may be only a solution as antisocial behavior declines significantly after the age of 40. In other words, we try to we try to maintain them around. We try to observe their behavior, say that it is not harmful. However, as we wait for such and such a patient to get a bit older, because as they tend to 40 years, it tends to actually decrease. Then under cluster B, we have the borderline disorder. It is associated with specific problems in interpersonal relationships, self-image, emotions, behaviors, and thinking. You get it? Yeah. In other words, it has problems in cognitive behavior, in cognition. People with the borderline personality disorder tend to have intense relationships characterized by a lot of conflict, arguments, and breakups. You get it? Yeah. They are just in conflict always with other individuals. This has to do with their cognition. They also have difficulties related to stability of their identity or sense of self. Someone tells you, I don't also understand myself. I find myself doing some things. You get it? Yeah. I just hate that person. I don't know why, but I'm all, every time I see him, oh, I just want to fight him. You understand? Things of that nature. Characteristics, it has a pattern of unstable and intense interpersonal relationships characterized by alternating between extremes of idealization and evaluation. Yeah, and intense and unstable interpersonal relationships. Yeah, they are not stable. They cannot have a friend consistently. Not just having a close friends, they can have the close friends, but they cannot maintain the consistency. Identity disturbance, like we say, someone tells you, I also don't understand myself. You get it? Yeah, it is markedly and persistently unstable, self-image or sense of self. Impulsivity in at least 2 areas that are potentially self-damaging. For example, spending like nothing. Someone gets money and starts spending, and it's not spending in an affirmative way, but in the other exploitative way. You understand? Yeah. Substance abuse, reckless driving, yeah, binge eating, and everything. Then suicidal behavior, gestures or threats, or self-mutilating behavior that is harming themselves. Yeah. Someone is not has such episodes of self-harm. Affective instability due to a marked reactivity of mood. Yep. They have mood swings. You get it? Yeah, their mood, they can react in anyhow over something very small, then they overreact just like that. They are not even stable. They cannot sit down perhaps to meditate. No, you get it? Yeah. Then chronic feelings of emptiness, no close friends, no owning anything, but it must be persistent. And then inappropriate, intense anger or difficulty controlling anger. That's also another characteristic. Then when it comes to the etiology of this behavior, yes, childhood abuse, neglect, and past trauma can cause such borderline behavior. Then parental conflict and abandonment, parents not caring about their children well. Also conflict between parents in presence of a child, it can cause such borderline behavior. Then the DDX, now in addition to the characteristics, mood disorders, it's very common. Someone cannot have a settled mood. Yeah, they are always jumpy. They can be excited, and then in just a minute they are kind of desperate, they're depressed, things of that nature. Then chronicity helps to distinguish from the bipolar disorder. I said bipolar is that disorder that combines both a condition called mania and a depression condition. It combines both conditions. That's why bi means it too. So it combines both the manic episode, that is the excited, and then the depressed episode, that is of low mood. Yeah. Treatment, we shall use benzodiazepines, including, for example, diazepam, or and mood stabilizers, including carbamazepine. By the way, the basic treatment for this is diazepam followed by carbamazepine. Yeah, those are 2 drugs. Then we have now the histrionic disorder. excuse me, we have the histrionic personality disorder. Yeah. The central features of the histrionic personality. Excuse me for that. I don't know what's happening to my keyboard. Yeah, now. Okay. So the central features of the histrionic personality disorder are the intense expressions of emotion and excessive attention-seeking behavior. Someone wants to be attended to all the time. You understand? It occurs a lot in children and some adolescents. So people with this condition often seek out attention and are uncomfortable with others that are receiving attention. You understand? It's not that they want to be, it's not only that they want to be attended to all the time, but they are even kind of jealous when some other person is receiving their attention. And we see this is common in children and adolescents. I think you have been following that up. People with they may often engage in seductive or sexually promiscuous behavior, or use their physical appearance to draw attention to themselves, attention from others. They can try to try to be to perfect how they look, so that others remove attention from other people and it gets shifted to them. Now, this is common in adolescents. They may also demonstrate rapidly shifting emotions and express emotion in a very dramatic fashion. And so these are all dramatic disorders under cluster B. Then the cause, diagnosis, and treatment. It is cause it is inherited and reinforced by families. It can be inherited, that is genetically, but also it might not manifest a lot when just inherited, but also families also tend to reinforce it by over caring on that particular child. You understand? They over try to provide whatever the child asks for without hesitating. Yeah, that is reinforcing such a disorder. Then the diagnosis, males present exaggerated masculinity. In other words, they are male characters. They over exaggerate at some point. Yeah, like that. And then, but the most diagnosis comes in the presentation, like we have seen in the previous slide. Treatment, individual and group psychotherapy helps to improve on the attention-seeking behavior and symptoms. But we can also attach it with antidepressants, for example, citalopram or venlafaxine. Yeah. And then we have the narcissistic disorder, narcissistic. Yeah. It is characterized by an inflated sense of self-importance, self-importance, that someone tends to feel more important than others in a certain condition. So people with such a disorder often believe that they are special. You get it from others. They require excessive attention. It's not just they have the other attention-seeking behavior of the previous slide, but they need attention because they feel they are special than others, because they feel they must be, they are unique from others. They take advantage of others. They lack empathy. They cannot feel what others feel, and are described as being arrogant. You get it? Such people with such a condition are described as being arrogant. Then the cause and treatment caused by cultural factors. For example, we can say the Western society's overemphasis on materialism other than family and religious values. They want to see how weighing this is. You get it? And instead of what will help or what will help the family move well. Then also another cause is the unempathetic and the neglectful parental behaviors. Then it tends to affect children. Then the children develop the narcissistic condition. Treatment is psychotherapy. Yeah, we try to give them a supportive psychotherapeutic treatment so that we can try to overcome the personality disorder. Then we have the avoidant behavior, or you can call it or personality disorder. So such avoidant disorder, it is under the cluster C, the eccentric disorders. Cases tend to experience an intense level of social anxiety. Yes, they tend to fear others, extremely self-conscious. They tend to avoid social situations and gravitate to jobs that involve little interpersonal contact. They don't want to be interacting with the people. You understand? Yeah. Avoidance often feel inadequate or inferior to others and are hypersensitive to rejection. They fear to be rejected. You get it? Yeah. Unlike individuals with schizoid personality disorder, avoidant cases do crave social relationships, but feel that social acceptance is unattainable. They would love actually to relate with others, but they feel like, what if I try to engage such and such a person, then the person avoids me. You get it? The person neglects me or sees me as if I'm too demanding on them. You understand? Yeah. So causes of such a disorder: shyness, introversion, social anxiousness all have substantial heritability. They can be inherited. And then parental overprotection and cautiousness may also contribute. Parents tend to try to protect their children. You understand? And they are trying to be so securing in that category. And also another cause may have excessive autonomic arousal, fearfulness, and inhibition. It may also contribute to such avoidant disorders. Then the diagnosis: unlike cluster A, avoidance strongly desire relationships and are more shy than antisocial. In OD disorder, that is in cluster A, patients in that category, they do not want relationships. That is it. And we saw how each and every disorder, people tend to avoid relationships. But here, these ones crave for these relations. They want them, but they are fearful to such depth of relationships. Treatment: we shall use anti-anxiety medications, and those are the benzodiazepines. We gave examples, and the citalopram as an antidepressant. Then we have the dependent disorder, still under cluster C. It is a psychological personality disorder in which individuals are dependent on others. They are too depending, not just attention seeking like in cluster B. Here they are just dependent on others. They want to be taken care of, cling to those they depend on, and often rely on others to make decisions for them. They have a strong fear of rejection and may become suicidal when faced with the disintegrating relationship. We have had cases, especially in love affairs, someone kills themselves or harms themselves because someone has broken them off. You understand? Yeah, and someone tends to harm themselves. You understand? Yeah, such cases, someone had become perhaps so much dependent on some other person. Those with a dependent personality disorder require excessive reassurance and advice and are commonly oversensitive to criticism or disapproval. Whenever they are criticized, they feel so bad once they are criticized by something. They feel like they have done something too huge. You understand? Yes. Then the cause, it is parental related, and then the diagnosis, dependent personality traits must be present by late childhood or early adolescent to make diagnosis. Because when someone is still in childhood stage, the early childhood, of course, such an individual must be dependent on the parents because they are still learning the world. But in late childhood, come to 14, 15, 16 years, then early adolescent, if someone is dependent, then they have such a disorder. Treatment: we try to give a supportive group therapy. Engage them with the cases of the same condition, or even other people perhaps went through the condition, or psychotherapist. Yeah. Then avoid the development of overdependence. When you are training, when you are bringing up your children, try to train them in a way that they are not over depending on you, the parent. It's easy to train our children in such a category. Then number 10, that is the last of these disorders, is the obsessive compulsive personality disorder. I told you OCD and OCPD are different. Now here we are talking about OCPD. So people suffering from this condition, the condition also called an narcissistic personality disorder, are so focused on order and perfection that their lack of flexibility interferes their ability to get things done and to enjoy life in general. They are not flexible, they are just tied on one thing. You understand? They are just obsessed with that one thing, and as if it is compulsory to do that. In other words, they are not flexible. Even if it changes, they feel like not changing with it, and even they don't have such sessions that they are enjoying. Little is accomplished because whatever the task for the obsessive compulsive, it is never good enough. That is for such an OCPD disorder. These individuals become involved and overwhelmed in detail and are often unable to see the bigger picture of how things are actually done. The cause, obsessionality and consciousness are heritable. That is, have a genetic link from parents. Then diagnosis, it is distinct from OCD. Secondly, patients can have both disorders, but most do not. Both can exist, the OCD and then the OCPD. Yeah. Then lacks intrusive obsessions and compulsive rituals. I mean, what comes from within themselves as they are growing up. Yeah. Then treatment, which we can give a psychodynamic psychotherapy and medications to impact comorbid psychiatric conditions. In other words, in summary, we try to treat symptoms and also give a supportive treatment. That is the OCPD. In conclusion, the hallmark of a personality disorder is repetitive patterns of problematic interpersonal relationships. We saw the general symptoms at the beginning of the lecture. We saw the general symptoms, yeah, that it has a lot to do with interpersonal relationships. A classic sign of when one is dealing with a personality disorder is when one feels angry, frustrated, defeated, manipulated, or irritated by a patient. Now that comes to ask the health workers. However, we have seen a strong link in genetics and in genetics. Most of these disorders can be inherited. However, even if it is inherited, it is also its manifestation is reinforced a lot by parents. Therefore, as health workers, when you are giving family therapies, enforce a lot on how parents bring up their children to avoid manifestation of the inherited conditions. This marks the end of our lecture. Thanks for moving with us from the start of the lecture up to this point in time. We have been discussing personality disorders, and the following have been our lecture objectives. I guess they have been achieved. Thank you. Let's meet again.